My name is Jennifer Lynde. I'm one of the fellows at Jackson Memorial Hospital here in Miami, and I have a couple cases to present that came in very short succession to each other, a couple blunt abdominal traumas, and we'll talk about those cases in addition to the trauma surgeon's perception of time. Maybe. Okay, so the learning objectives evaluate the mechanism and associated injury or associated risk factors, detailed diagnostic and treatment interventions, and then evaluate team and time management skills during critical trauma care and resuscitation. So our first patient is patient Yuma. This was a 49-year-old male who came in via ground EMS after a motorcycle crash. Of note, you'll see that I've listed the time there. It was 1:49 in the morning. That will be important as we go through. I will list the times of each event as they occurred. The patient was unknown to be wearing a helmet. The event was witnessed and he did have positive loss of consciousness. The EMS crew had difficulty obtaining IV access en route, so he came with nothing, no IO, no IV, nothing whatsoever. Initially, his heart rate was 87, but quickly on repeat was tachycardic as we got him on the monitor, and his blood pressure was 116. His oxygen saturation was 94%, and his GCS was 10. He basically seemed obtunded, would not track or follow commands, basically wouldn't respond to our talking to him. He did have an obvious left thigh deformity, and his initial fast was negative. I mentioned that we did a fast so soon because during the fast, we were trying to get IV access. Like I said, he came in with nothing. He was a larger gentleman. BMI was probably 30 to 35. And so we were placing central lines because based on his vital signs, we thought he would need central access. And in doing so, it took longer than expected based on his body habitus. So that's part of the thing here. So while somebody was placing a central line, somebody else was doing a quick fast and running through the primary survey. After we got the introducers placed, we had two teams working simultaneously on them, one at the femoral site and one at the subclavian site. The patient was then intubated by anesthesia using RSI, and his initial VBG was 7.09 with a base deficit of -12 and a hematocrit of 42. At 2:02, we started giving 2 units of whole blood for his tachycardia and hypotension because by this time his pressure was less than 100. He also was in more respiratory distress, even intubated. So we ended up taking him off the ventilator and bagging him by BVM through his ET tube. He also got 2 units of blood and another unit of a unit of FFP for continued hypotension. And of note, the blood products were given through his femoral central line. After those were in, that was approximately 2:12 in the morning. We gave 3% sodium chloride for suspected brain injury, given that he was not wearing a helmet and came in obtunded. So next steps from the panelists, ideas.
Dr. Antrak, your comments, please.
Yeah, so I assume that you say fast, was that if it wasn't E-fast, regardless, at this stage, since he came in with a normal pulse and blood pressure over 100 and he deteriorated, I would repeat the fast and do an E-fast, so to be sure that both lungs are fully expanded. And to recheck the abdomen, and I would be sure that he was in a traction splint on the left leg for a presumed femur fracture, through which he can be sequestering a large amount of blood, especially for such a big patient, and then see how he responds to the blood. Is he a transient responder, non-responder, or a responder? And that's what I would be concerned at that point before making a decision. where he goes, whether to the operating room or whether if he stabilizes, then you can go ahead and do a CT scan. While he's there, I'm going to also consider doing a chest X-ray and a pelvic X-ray, and at the same time X-ray of the femur.
Thank you, Dr. Antrak. Dr. Kasim, your comments, please.
So obviously a big gentleman and took much longer to get the central line than anticipated. So you need to get a chest X-ray as quickly as possible to make sure that the central line is in the right place and there was no possible injury. And a chest X-ray will be very, very helpful. And I would agree with Dr. Untrak with everything he has said. Repeat the fast to see if he has any pneumothorax as well as an abdominal X-ray, and to see if there's any other discernible injuries, and put the patient on traction splint, because you could lose as much as 3 liters of fluid in a femoral shaft fracture in a big man like this. So he's not stable. Now you've given him 2 units of blood, some FFP, and yet you have not been able to get him to hemostasis. And so I think you will have to move fast to find out which cavity is filling up with obvious blood loss. And whether it is the chest, or abdomen, or pelvis, or all 3. I will stop there.
Thank you, Dr. Kasim. Dr. Ochman, Boston.
Well, this patient cannot go anywhere. You have a patient in the trauma bay who is hemodynamically unstable. You need to know what's going on. Chest and pelvic X-rays by ATLS is part of the primary survey. They're called a chance to primary survey. Sometimes we do it later because we don't feel, but in this case, it's very important to do it earlier. You need to rule out the hemothorax, you need to rule out the pneumothorax, you need to rule out the pelvic fracture as a source of the bleeding, and you can repeat the fast. That's another alternative for diagnosis of hemopneumothorax. If you have nothing and the patient is kind of crashing in front of you, you can put bilateral chest tubes empirically. Still putting the bilateral chest tube, sometimes you see blood coming and you still don't know if it's coming from below or above the diaphragm. So the chest X-ray in that case is very helpful. So you are stuck here. You need to transfuse until you know where you are going. Obviously, this patient cannot go to the CT scan. The question is, if he has a pelvic fracture and not intraperitoneal bleed, you have a 70% chance that the problem bleeding is in the pelvis, so you should go to IR. If the bleeding is in the abdomen, you should go to the operating room. So, sorry, I am very sorry. I keep getting phone calls. I apologize. Thank you. Bye.
Thank you, Dr. Ochman. Dr. Supa, Bangkok.
I agree with the previous evaluation and management suggested by other before me. I'm a little bit concerned about the right subclavian line that was put in earlier, because the subclavian line is not an easy line to put in, especially in the emergency situation where the patient cannot be positioned properly, and it can be a source of bleeding or vascular injury, like Dr. Kasim mentioned. So I agree with checking his chest with either listening or do the e-fast or do the quick chest X-ray to rule out the chest injury or bleeding on pneumothorax. And I like to get a pelvic X-ray too, because it's other possible source of bleeding in this patient, and check his response to the resuscitation. But likely he will be in the OR very shortly. Thank you.
Thank you, Dr. Supa. Dr. Lynde, we go back to you.
Okay. We're still on the recess bay. It's now 2:25 a.m. Remember, he came in at 1:49, at least by, that's like walking through the door. Now he's bradycardic to 42, hypotensive even further to the 50s, despite 2 units of whole blood, 2 units of PRBCs, and 1 unit of FFP. So we gave atropine and calcium, and he had improvement in his vital signs. 2:35, we took his chest x-ray and pelvis x-ray, because we had been busy making sure things weren't going to deteriorate further. No traumatic findings, no pneumothorax, no hemothorax, no pelvic fractures, nothing. At 2:42, he again became hypotensive despite ongoing transfusion. So now we started MTP and he got hypoxic again. So this time we did the empiric bilateral chest tubes. We got nothing out of the right chest, but the left chest had 100 cc's of blood. Again, not a lot. Could have been, just some blood from some rib fractures and from a chest tube placement, honestly, but nothing that would make me say it's definitely coming from the right chest. Of note, here's his chest x-ray. You can see the ET tube is in the pretty good position. He has no hemothoraces. It's kind of a limited film given his body habitus, but you can see there's maybe a little elevated right hemidiaphragm. Otherwise, pretty normal. History of a prior clavicle repair. No other big fractures. Nothing crazy. And then here's his pelvis x-ray. No widened pubic symphysis. You can see the introducer there, and no other fractures whatsoever. So now, similar to before, we come to this same basically fork in the road. What to do next? Fast x-rays, DPA, CT scan. He's still hypotensive, so that's definitely not an option versus the OR. What are we moving forward? So we repeat as fast, and it shows that it's grossly positive in the right and left upper quadrants as compared to before when it was totally negative. And of note, every product we gave was through that left femoral line. So we take him, he came in at 1:49, we're in the OR, and we've made incision by 3:05. So over an hour to laparotomy. He had a very large grade 5 liver laceration with massive disruption of multiple segments. After making the laparotomy incision, we immediately extended to a right subcostal exposure and packed the liver. After letting anesthesia catch up a little with MTP, we then tried a left lobe hepatography using a tongue of omentum as packing, and then a large chromic suture on a blunt needle. We performed a Pringle maneuver as well and packed him. And we still didn't get much improvement. His pressure was still low despite massive resuscitation. We placed an additional chest tube on the right because it seemed as though his diaphragm was billowing into our field. By that time, the patient had become bradycardic. We performed a left anterolateral thoracotomy to rule out the left chest, since he also had the 100 cc's of blood out of there. And based on what had been happening in his imminent code, if you will, we thought that would be necessary. So we opened the left chest, pericardium had minimal clear fluid returned, and his heart rhythm noted to be agonal. Then at 3:50, he became pulseless. We started ACLS, and then he expired at 3:54 despite massive transfusion, aggressive medical and surgical managements. And that was at 3:54, so approximately 2 hours after arrival to the hospital. So we considered for this opportunities for improvement. like time to initial access. The 3 teams were working on getting IV access at the same time to repeat fast, maybe earlier fast. You know, we did it approximately 50 minutes into his hospital admission. Maybe we should have repeated that faster, as some of our panelists have said. And then maybe we should have just gone to the OR faster. We could have repeated the fast earlier, performed a diagnostic peritoneal aspiration, and that would have given us blood, obviously, since we had massive hemoperitoneum, and then we could have been in the OR sooner. We have another case that's similar to this, but are there any questions before we proceed to the next case?
Dr. Anzrak, go ahead.
Yeah. So looking at the X-rays, I didn't see the introducer in the subclavian. I believe the right subclavian, or from what I recall, you put an introducer in the left femoral, so not in the broken leg, right? So the right side and the left subclavian. But I don't see an introducer in either subclavian. And then it looks like you have the introducer in the left femoral vein, the same leg that had a clinical fracture. There you go.
Yes.
Is that right? Is
yes,
that left?
Because we were trying to get access. That was not ideal, but at this point we didn't we couldn't even get an IO. So we were trying, and we understood that it was in the vein, but was what we could get at the time.
Okay, so you weren't able to get the subclavian access, is that right?
No, the subclavian was there. It's not visualized.
I don't see it.
I
don't see it at all.
This is part of the introducer here, and so I don't know that it's just not visualized on this chest X-ray, but it was definitely placed in a subclavian because we used it intraoperatively, and that changed a bit of how we proceeded, because in the operating room when we saw his liver, we then switched transfusion to the subclavian line. I think it's just not visual.
Anyway, yeah. Oh, okay. I mean, it just doesn't show up there. But anyway, just a couple of comments. So in placing the catheters, I don't know if they use the ultrasound. In my generation, we didn't have ultrasound wasn't done till the mid to late 90s, and we put in thousands of lines just by without it. Sometimes using a Doppler to see where the artery is, and then but if you were using it in this case when he came in, you would have been able to judge the fluid status by whether the veins were expanded, dilated or not. Number one. Number two, it's a motorcycle accident, and I had worked for a couple of years in West Africa where a lot of people ride motorcycles and scooters, and they fly off of them, and sometimes you see when they land on the back, you can have a rupture of the posterior part of the liver. You said segments 7 and 8, so I think there's a possibility that he had a retrohepatic IVC injury. And just following up on what you said, an earlier diagnosis. So once you ruled out a pelvic fracture, and Dr. Hockman's concern about doing a laparotomy in the presence of a pelvic fracture, that's no longer an issue. So you can just, when he deteriorated, you could take him straight to the operating room for a laparotomy, given that there was nothing coming out of the chest, and given that the chest X-ray looked okay. And at that point, if you saw that he was bleeding a lot before he, saving the 10 or 15 minutes before he became agonal, one possibility would be to do an immediate sternotomy and do the Schrock shunt, which you wouldn't do often, but this might be a motorcycle accident. You don't know how he landed, but those segments, that's a possibility in a patient doing well, and you couldn't be faulted for going ahead and putting, you do a sternotomy, it's rather easy to get control of the suprahepatic vena cava, and then you can quickly get control of the infrahepatic vena cava, and then you can tamponade the aorta or put a Reboa in to do the fourth, and then the Pringle maneuver, and then you might have had control of the bleeding well enough to go ahead and resuscitate him. And then there's Dr. Supa's incision of the right thoracoabdominal incision, which gives you good exposure to that part of the liver. That would have been the other option. Quickly it's probably what Dr. Super would have done. Quickly extend the incision from the abdomen into the right chest so that you can get a good view of the retrohepatic cave and try to get control. So those would be the options, but it would have been heroic in this case. But I think it's a good point that you mentioned to try and save a few minutes and make a quick judgment. And the early chest and pelvic X-rays would help simplify the algorithm, so you don't have to worry about opening an abdomen when the bleeding is all in the pelvis and then you burn the bridge. Yeah.
Thank you, Dr. Ontrak. Dr. Ochman has a question.
Yes, more than a question, a few comments. First, it's well known that the fast can be negative initially. And this is another thing that we always rush to do the fast. And I can see that you presented this in your M&M and you have a lot of like diagnostic peritoneal aspiration. And one of the advantages of being so old like I am is if it's something that doesn't work or doesn't make sense, whatever, I've probably done it and I've done it many times. So I can tell you that it doesn't work. It sounds very good on paper, but when you try to do it, it doesn't work. So I wouldn't do that. The approach to this, if you go to the OR, is the moment you see the bleeding from the liver is to do a Pringle maneuver. If the bleeding continues, this is a retrohepatic, it's an hepatic vein injury. And what I found, it works very well and is very counterintuitive. I learned this from an oncology surgeon many years ago, is to keep the patient with a very low CVP around 5, which is very difficult to convince anesthesia not to give fluid to a patient who is exsanguinating. But that will give you a chance to be able to access those veins and suture them, because otherwise you have too much bleeding and you cannot see. This is a huge guy, so it's incredibly difficult to see in that area. So this is a generic recommendation. It's not a critique of what you can do, because being in that situation is horrible. A morbidly obese patient trying to get access to the retrohepatic IVC is very difficult. And I have to say, one of the advantages of this conference was Dr. Supa presented a similar case a few weeks ago, so months ago, with a very interesting approach of opening the chest and accessing the retrohepatic IVC that way, which I didn't do before, and I had the chance I will do that before doing anything else. Was a brilliant approach, I have to say, how Dr. Supa got control in that retrohepatic IVC injury. And finally, an editorial comment. This was being done at 3 in the morning. And this is something that I kind of like research extensively in terms of how to change our practice. There has been many studies, just to mention a few. If you are awake for 18 hours, your reflexes when they are measured are the same reflexes that the patient who has an alcohol level above the legal limit. We continue to do 24-hour calls, and I imagine that when, Jennifer, you get to be my age, people will say, oh my gosh, you guys were doing that, that's insane. I think it's absolutely insane that we continue to do 24-hour calls. The military don't do it, the astronauts don't do it. Anyone who has a position of responsibility in something that is really very intense, they don't do it. You will never get into a plane when a pilot didn't sleep for 24 hours, but we will get into an operating room with a surgeon who didn't sleep for 24 hours. Yes, your reflexes are going to be slower. You are not going to be as sharp at 8 in the morning like you're going to be at 3 in the morning when you've been up since 6 a.m. That's very clear, but we keep doing this and it's so difficult to change. I'm hoping that one day will change. I trained at the time that residents, we were working 120 hours a week. Unfortunately, that has changed. But this thing of the 24-hour calls has to change. Here, we eliminated the 24-hour calls during the weekdays. We fortunately still have it on the weekends because we don't have enough people. But the 24-hour call should be eliminated. I think this is the result. I am not saying that it will be a different in this case, because this is kind of almost a guaranteed lethal injury, but your performance, I'm pretty sure, would have been much faster if this would have happened at 10 in the morning, not at 3 in the morning. That's it. Thank you. I'm sorry. I keep getting phone calls. I apologize. There are a bunch of emergencies. There are 3 surgeons already here, but I hope I don't get called into all these things. Thank you.
Thank you.
Thank you, Dr. Ochman. I think Dr. Kasim has a question.
Well said, Dr. Osman. Everything you said is right on the money there. I think I would like to say a couple of things. When you get a case like this in the middle of the night, I've made it a habit always to call a friend, somebody who might be either sleeping or maybe awake, maybe was not on call the previous day. He might be a little more awake to give you some verbal help. And the second thing is, when you have a massive injury to the liver, you got to exercise a lot of patience. Young surgeons are very quick to go for catgut sutures and this sutures and that sutures to suture the liver up. You know, they want to reconnect or reestablish the perfect anatomy as much as possible. But I think that'll be the wrong thing to do. I think, in my opinion, just packing the liver to the best of your ability to see if we can stop the bleed. And in spite of that, if it is still bleeding, I think you need to suspect the patient have a retrohepatic injury till proven otherwise. And then you need to go to plan B, plan C, whatever it is you have in your armamentarium to stop the bleed. I think packing and being patient is a very, very vital thing to do. And young surgeons, you know, who are on call in the middle of the night, they sometimes fail in that respect. I think most of the stuff Dr. Horstman has said is absolutely correct.
Thank you, Dr. Kasim. Dr. Lynde, we have also a question from Dr. Kobe from Japan, but I'm not sure. What reason would you guess why first fast is negative?
So I think, as Dr. Hoffman said there, it's a certain volume of blood that was present. And then after we transfused, there was more blood that was coming up through the hepatic injury, and then definitely in the abdomen after that, because we gave so much blood in the trauma bay. And so by that time, the only thing the repeat fast would be is positive. And to the other questions, the anesthesia was giving epinephrine and stuff before we opened the chest. I think we're not trying to be heroic, but in trying to save a young man's life, we also wanted to make sure the left chest was negative, given that we had blood, despite the chest x-ray that appeared clear or almost totally normal. And then Dr. Antrak's question about the autopsy, it showed the liver injury. Honestly, I don't know that they actually took him and fully did the autopsy, but I'll have to check into that a little bit more. But I think what we learned is that, yes, we could be patient. We did discuss a Schrock shunt. We discussed IR, embolization of the liver after packing, and Pringle, if we could get him stabilized. But when he became bradycardic, and certainly after we opened the chest and he was more coagulopathic, and that's when we thought that less is more. Okay, so we have a second case. It's a little bit quicker, and it will get to the point that we're going to discuss at the end for both of these cases. So this is second patient, Dodge, came in the same evening. So the other patient expired at 3:56. This patient presented at 4:22. So I was in the operating room finishing with the other patient when my attending Dr. Gabriel Ruiz and my other trauma team members were in the we're in the trauma bay when this patient came in. A 57-year-old female that had presented as a pedestrian struck and dragged by a vehicle. She was noted to be under the car on scene, and this was witnessed. She came in with a heart rate of 90, respiratory rate of 26, blood pressure of 88, and an oxygen saturation of 89% on a non-rebreather mask. She was intubated almost immediately by anesthesia. She did have peripheral IV access, She also had breath sounds equally bilaterally after intubation. We went ahead and placed an introducer because we were concerned that she would need MTP, and we started it through the introducer in her femoral vein. She was noted to be pale and diaphoretic. Prior to intubation, her GCS was 11. She also, on secondary exam, had large abrasions across her thorax, including the abdomen and chest, similar to road rash or like being dragged by a car, essentially. Her initial venous gas was 7.16 with a base deficit of -7 and a hematocrit of 35. As I said, she had lots of abrasions. So questions or thoughts about this woman, what you do next? We've started MTP. She's been struck and dragged by a car. Obvious abrasions to her thorax.
Dr. Supa, would you like to make any comment?
So obviously she's in shock in this lady, and I think we have to find the source of bleeding and try to control it as quickly as possible. And fast should be done for this patient for sure to check her abdominal bleeding or cardiac tamponade, or you can move up to the chest to check for hemothorax. And chest X-ray and pelvic X-ray, I think should be obtained if it's not so difficult. And DPA, we nowadays rarely perform it with good fast exam, and you can repeat the fast many times. I think the need to do the DPA is decreasing. And CT scan cannot be done at this point. And I think she has blunt trauma. She has possible head injury. We can go ahead and transfuse her with blood and fluid to maintain her blood pressure. And we should book the OR at this point because she's likely belongs in the OR. Thank you.
Thank you, Dr. Supa. Dr. Kasim, your comments?
Well, having gone through a nightmare night from the previous case, I think you'll be much more awake with this one quickly, hopefully, and start, your brain will be recalling all the mistakes that you made in the previous case, and this one you will be a lot more alert and get to the bottom of the case as quickly as possible to see where the patient is bleeding. And hopefully this patient is not as big as the last one. Hopefully this is a tiny lady, and yet she's had significant injuries. So you need to find out which cavity is filling up with blood, whether it is the chest or abdominal cavity. And sometimes you just have to go with your gut feeling, your probability. Very quickly you put 2 chest tubes in to see if there's any blood. If there's no blood, then you have to go, the patient is bleeding in the abdominal cavity. Then comes the problem of, is it pelvis or it is the abdomen? And by and large, it will be most likely abdominal cavity, and one of the organ is bleeding somewhere. So DPA, I don't think I have done a DPA in the last 15 years. And certainly Dr. Trunke used to say, don't ever send a patient who's hypotensive to the CT scan because that's where she will die. And catch up with the blood product, very little fluid, and the patient belongs in the operating room. Thank you.
Thank you, Dr. Kasim. Dr. Ochman, Wilson?
So the approach to any patient who essentially you don't know what is bleeding this is kind of like always the same. Chest and pelvic x-rays, ultrasound, and meaning a fast, and you go from there. Here you put diagnostic peritoneal aspiration and not DPL. DPL is still part of the armamentarium according to ACLS. I used to do like 2 a night when I was chief resident. Some of my residents now graduates having done 1 maybe. It has been abandoned because it takes time. It takes a good 20 minutes. And for an unstable patient, it doesn't work. Diagnostic peritoneal aspiration is something else. It's just tapping the abdomen, hoping to get blood. And that really doesn't work. And trust me, I've done too many of those things trying to get, and I never got anything useful by doing that. Here you have 2 competing priorities. You have a patient that got potentially a head injury, and so would you want to over-resuscitate and keep the blood pressure high? Meanwhile, can have an intra-abdominal injury or an intrathoracic injury, be bleeding, and you want to have a controlled hypotension until you get control. So making the diagnosis quickly is very, very important. Sometimes it's very, very difficult, and as Dr. Kasim say, going with the gut feeling. And I will give a scientific explanation for the gut feeling. The gut feeling that many of people describe, because they cannot verbalize how they know that there's something, is a pattern recognition. You have to have experience. The pattern recognition is done by the right side of the brain, which is nonverbal. So that's the reason it's very difficult for people to explain. And you will see many of the old physicians say, oh, is this? I say, how do you know? Oh, I had a gut feeling. It's not a gut feeling. It's having seen hundreds of thousands of cases, and it's a pattern recognition done by the right side of the brain. And that's the reason they are more frequently right than wrong, is experience. But until you gain the experience, the best way to go is to follow all these steps one by one very quickly. So for this patient, it's fast and x-rays. And with those, you should be able to know where this patient is bleeding and act accordingly, either chest tubes or thoracotomy or laparotomy or pelvic packing or IR or whatever. But that's the way to go with this patient. Thank you.
Thank you, Dr. Juan. Dr. Antrak, any comment?
Yeah, so in this case, about the last issue, the transfusion, I would keep the patient where she is right now. The pulse was 90 something, the blood pressure was 88. So if it stays there, I think those were the numbers, the heart rate 90, SBP 88. So that's, if you keep her there, I wouldn't push too much blood at this point. And then I agree with the others. You got to quickly do the chest x-ray, the pelvis x-ray, the mechanism of injury. Somebody that's a pedestrian hit frontally by a car, often there are bilateral femur fractures, which by itself is an indication of very severe other injury, very high likelihood of mortality because of the mechanism of injury. So, she had initially Glasgow Coma score of 11, so assume that she didn't have a devastating closed head injury. And so very quickly, look at the chest x-ray, look at the pelvis x-ray, assess whether or not there are femur fractures, and then do the fast. And if there's no pelvic fracture, then and she gets hypotensive, and the chest x-ray looks okay, you put 2 chest tubes and there's no drainage, then I think it's reasonable to just take her to the OR if she becomes more unstable and do a laparotomy. I think that would be the safest course.
Thank you, Doctor. Dr. Lynde, we go back to you.
So we did repeat that fast, did do the fast. So she came in at 422. She was intubated. Her fast was finally done at 440. So almost 20 minutes later, was positive grossly in the right and left upper quadrants, similar to the last patient. And she was more unstable, now more tachycardic. Blood pressure is still the same, but more tachycardia. And then we had given her so far up to this point 4 units of blood and 2 units of FFP. So despite ongoing transfusion, she still was the same, but now more tachycardic. So we went to the operating room. We actually left the trauma bay to go to the operating room at 4:50. So in the operating room, say 4:51 or 4:52, actually made laparotomy at 5:06. So almost 15 minutes later, enough time to get her moved over and anesthesia set up. And then again, she had another destructive liver injury, now with basically her what we found when we made initial laparotomy was that the left side was disrupted, but the main side again was the right side. We extended our incision with the subcostal exposure and packed the liver initially. We did, tried all of these things, but when we had initially reached our hand posteriorly to the behind the right side of the liver, we just basically felt a cracked liver that communicated, that communicated with the veins and went down to the IVC. It didn't involve, frankly, the IVC, but was quite close. So we tried everything again, the same things. We even went so far this time as to say, hey, IR, can you get ready? Because we need your help in the trauma OR. However, despite packing and pringling, we considered her shock shunt, but as we were considering that, she did become bradycardic and she was still massively exsanguinating despite MTP and aggressive efforts. And eventually she did expire at 6:17, so almost an hour and 15 minutes into our procedure. So we could have been quicker potentially getting to the OR, but she did have a massive injury. But what I really want to talk about is how our perception of time, especially during the initial case, and Dr. Hoffman in Boston basically alluded to this, and this isn't about 24-hour shifts or anything, but just our perception of time during trauma resuscitation. Here at Jackson, we don't have video review capabilities yet. I have been places that have it though, and it's helpful. We've reviewed, I reviewed pediatric trauma cases when I was in residency, and it was actually pretty helpful. But there's a new paper coming out, so it's going to be published about our perception of time. So basically they took providers that were in the trauma resuscitation bay, they gave them surveys, they were timed and basically monitored on a video, and then found that clinicians overall underestimated the time that they needed by 28%. So if resuscitation was actually 20 minutes, the clinicians thought it was 14 minutes. And this misperception was especially worse when procedures were involved. So like for the first patient, we put in central lines, we put in chest tubes, he was intubated. The second patient was also intubated and also got a central line. So during those procedures, you think I can do it in 30 seconds, have the line in. It may actually be longer, especially in a patient that's difficult. So maybe an obese patient trying to get a line in the groin is not as easy if you're dilating and not able to pass the dilator as easily without the wire bending. So basically what we're gonna hopefully try to do, as Dr. Ruiz, he was the unfortunate attending on that night for this marathon of stuff. We also had another patient come in that we took to the operating room right after her, but he had a better outcome. What we'd like to do is do a quality study where we try to record times as we're going through critical care traumas that come in and we're actively resuscitating, record times and see exactly how far off we are. And perhaps do surveys of both residents, fellow staff, and nursing staff to get an idea of what the entire team thinks in addition to just the staff on the case, because it matters, getting an IV, getting labs drawn also takes time, and those are what you would consider procedures as well. And so all of those other things add up and can affect how long you're in the trauma bay. So I'd like to hear other thoughts from more experienced people.
Thank you, Dr. Lynde. Dr. Kasim, your comments?
Well, when I was young, very young, I actually was in the war situation, where people were shooting at each other, and I was on call, and I remember very clearly after 2 cases in the middle of the night, you're pooped, you're done. You know, the efficiency was not there. And when I look back now, some of the stuff that I should have done, could have done, and the right side of the brain really didn't work very well. And I think Dr. Hoffman is absolutely right. You know, I didn't realize at that time that uh, we human being, we are not superhuman being. We are not Superman that we can perform all kinds of things in the middle of the night. And he pointed out, you know, the astronaut, the pilot, you know, they don't have this kind of call schedule, but we continue to do this. And I remember when I was young, I was on call for sometimes 7 nights. And those things don't happen anymore, but still, there is room for improvement. How we perform a major trauma, especially in a place like yours, where you can have 3, 4 patients show up in the middle of the night. Um, I feel sorry for Dr. Ruiz that he got 2 cases like this, and he probably felt devastated, losing 2 out of 3. I would feel devastated if I was in that situation. And I think our system is broken, and Dr. Hoffman is right. We need to correct this. I wish somebody would listen to him.
Thank you, Dr. Kasim. Dr. Antak, any comments?
Yeah, so I think about the passage of time. Probably this is well known to psychologists, but you know that if you're busy, you know, if you're not busy, you get bored. If you're very busy and you're doing things, especially if you're doing things that you enjoy, that you find interesting, your mind is focused and you're just concentrating, and you become unaware of time, and because of that, it seems to pass quickly. You know, they say time flies by when you're having fun. Well, if you're busy, your mind is occupied, you're concentrated, you become unaware of everything else, and so the time goes by faster than you're aware. So I think that's pretty straightforward. But I think you kind of, you know, when a trauma patient comes in, you try to go through the list, and a central line may take you a little bit longer, whatever, and you know, but I think it's still reasonable to be aware of how much time is going by. And I think if you know that, and you know that that's a pitfall, then maybe, you know, that's why they have the clocks in the ER and in the trauma bay and the OR. But and then about this case, I think it's actually helpful to see the pathology post-mortem if the patient dies, especially if the autopsy was done by your pathologist. And I know you're dead tired after this, but I try to go down, look at the anatomy, talk to the pathologist. They need to know that if they see a belly full of blood and laceration, okay, they have a cause of death, but you know, they need to know, they don't know that you're interested in what the retrohepatic cava looks like, and they can do the what's the eponym for that, where they basically just eviscerate the patient, turn the organs over. You can see from both sides. This typical the classical autopsy, where they eviscerate on block and then they dissect the organ, so you can look both sides and see exactly what happened. About management of this kind of injury, the mortality is very high. Dr. Supa had an excellent result with a right thoracoabdominal incision. And the issue is, if there's a lot of damage to the IVC or the veins, will that be helpful, or would it at least getting control of the bleeding with a Schrock shunt, an atriocaval shunt, will give you immediate control of the bleeding? Then you have, you know, you've got 30 or 40 minutes to figure out what to do, whether that's a right lobectomy or whether you can repair, you know, if it's not the vena cava, but the middle and right hepatic veins are avulsed. Well, then you can quickly fix that, and then you have good exposure and good control that you can do with a patient not in shock. You can go ahead and complete whatever the lobectomy you need to do. So that might be the one strategy for the future. Now, most of us have never done a Schrock shunt. I haven't done that, but we've all done sternotomies and cannulated the atrium, and you can see that that's a snap. It's very much quicker than most anything else you can do. And then in this case, I was going to say that a patient that is an apparently non-responder, if you think she's a non-responder and you're going off to the OR, you can have a second-year resident or somebody go ahead and get a Roboam. That would temporize a little bit. It'll buy you some time to get to the OR. Just shut off all the blood flow to the liver completely, and that's the part of the 1/4 of the Schwach shunt, and then you just have to, put in the chest tube and in the cava and put the encircle around the suprahepatic cava. Is very easy from within the pericardium, and then just the suprarenal cava and the Pringle maneuver, and you're done. And then you can, you have a reasonable amount of time to proceed. Now that's a fantasy. But that's a possible strategy that, having seen 2 in one night, and especially the mechanism of entry, thrown off a motorcycle, landing on your back, or being smacked by a car, however it was done. But I think looking at what the injury looks like anatomically, that'll give you additional data that you can remember to see what these injuries look like. If they're both the same, and it's more commonly that type of an injury, then you're ready to, you'd have more of an idea the third case where the injury is going to be and what you need to do. And so as discouraging as these cases are, eventually that's how you get the expertise to know how to deal with a very difficult clinical problem. So, to be optimistic, do the best you can. And they both had very high likelihoods of mortality, and you did the best you could. And a couple of minutes here and there, okay, I mean, we're all aware of that, but don't, you weren't asleep at the switch.
I do. I can say that I've never seen a Schwach shunt or even practiced it in the lab, but I think that's something that we could do as trainees. That way, if and when it happens, we'd be better equipped. There's no better place to do it than with a cadaver in a learning environment where you can make mistakes and not be punished.
On cardiac surgery, do you still during training, do you go ahead and cannulate when your senior resident cannulate the atrium? They put the atrial cannula in above and below and all. Yeah, so you can very quickly get around, and then just organize with the residents, organize a pig lab or dog lab, whatever, probably pig lab now. We used to operate on dogs, but just organize that. And although it's not, the pig is probably better anatomy, the dog is too easy to operate on, but about getting exposure, and basically it's having the patients already supine. And if you have the means to do it, that's probably the one thing in this case, if that's the injury, to the one thing that might work if you mentally prepared enough and you have all the things you need.
Thank you, Dr. Antrak. Dr. Supa Mangok.
These 2 cases, they are severe injury patients, and I think mortality is possible for them. And you did your best, so I think there's nothing to regret. About how to improve the outcome in this patient, I think number one, at the rider, you have the OR very close to the trauma bay. So the decision to move the patient to the OR earlier may be vital to improve the outcome in these 2 patients. Usually the attending will be the team leader, and they will think about the indication to move the patient whenever they need to be in the OR. We may not need to complete all the A line, C line before we move the patient to the OR. Sometimes I think intraoperative resuscitation is more effectively done than in the trauma bay. You have anesthesiologist to worry about the tube, the lines, and you can worry about which chamber to open. So I think we will be more concentrate on the operative field. And second thing I learned from the rider trauma, Dr. Namias taught me to cut everything between you and the bleeding. So basically, when you find the deep bleeding and you don't know how to stop it, you have to see it first. So usually with the retrohepatic bleeding, I usually start with Pringle, and if venous bleeding continue, I will perform packing. And if packing doesn't stop the bleeding, then I'll start cutting more. I'll start cutting maybe right thoracotomy, cut the diaphragm to expose everything in the midline and try to stop the bleeding. I once saw Dr. Pisano, if I remember correctly, he cut the iliac artery to expose the iliac vein venous injury and repair it successfully. And Dr. Sleeman helped do the anastomosis later. And the patient survived. She had cardiac arrest after gunshot wound. So that was impressive. Cut everything between you and the bleeding. It's the important thing I learned from the rider. Thank you.
Thank you. Thank you, Dr. Supa. Dr. Ochman, Boston.
Just to add to Dr. Supa's comment, that's the same apply to a portal vein injury. Cut the pancreas, otherwise you have no exposure to the portal vein. And after that, deal with the pancreas, transect the pancreas later. No, these are great cases. I don't see any fault in any way, shape, or form the way those cases are handled. The lethality of these cases is extremely high. Again, if there's something, if there is something stupid or doesn't make sense or doesn't work, whatever, I say that probably I beat everyone here at having done those things more than once than anyone else. So the atrial cable shunt is a good principle, but usually by the time you do it, it's too late and it takes time. So I think that there are other options that in my experience were better, like keeping the low CVP. And now after seeing Dr. Supa, that approach through the extended incision, the dividing the diaphragm, which I can't believe that I didn't know that before, is an excellent approach. The reason I am so aware of the limitations imposed by the lack of sleep is, Dr. Undra, you probably will remember my previous boss, who wasn't really a nice man. I had a case at 5 in the morning, I remember, where I made a mistake and I caught it, but it was a mistake that it should have never happened. Essentially, I did an anastomosis of the bowel, essentially in a closed loop, which the way I normally do an anastomosis of looking at the mesentery, it never happened. And I look at the clock and it's 5 in the morning and I was up since 6 in the morning the day before. So that day I say, okay, I fixed it, nothing bad happened, but say, I'm not doing 24-hour calls anymore. And I told my former boss, and my former boss was threatening to fire me. And he went to the chairman of surgery and saying that he had a trauma surgeon who couldn't do his job because I was refusing to do 24-hour calls. So I had to get all the research about the lack of sleep and the problems lack of sleep to present to HR. So eventually he couldn't fire me because I have that information. So, but he tried to fire me with the argument that I was not a good trauma surgeon, that trauma surgeons don't feel tired, that the adrenaline wakes you up, and all that type of BS that we know scientifically is not true. And we criticize people who do things unscientifically, and we have all these anti-vaxxers nowadays and all those things. And many of the things that we do in medicine are unscientific. And they say that the adrenaline will wake you up. Yes, it will wake you up, but it's not the same. Your reflexes are not the same. Your clarity of thought is not the same. Yes, you can do things that other people cannot do, but that doesn't mean that you're doing it correctly. So this perception of time, yes, it gets distorted, but I think that this is something that we will look back in a few years and say, how the heck we were doing that for so many years. That's it. That's all my editorializing here.
Thank you, Dr. Ochman. Okay, thank you, Dr. Lynde. We go back to you.
Oh, thank you, everyone. Regarding the research about this, we actually had a great fellow talk on it recently where our fellow Dr. Cohen went through all of that research that you talked about and what the military does with, they have a program where they basically are able to predict how well you can, how well you get back to normal function and functioning well. And so we're actually compiling sleep schedules so that we can input that information into this DoD software so that we can maybe make a better attending call schedule, a better fellow schedule, because fellows do Q3 24. Even some of our attendings are doing 24-hour shifts, depending on the availability of other surgeons, depending on who's on vacation or at conferences. So I think there's more work that we can do to help this. I was on a 24-hour schedule this night, and we had 27 alerts, and it was a very busy day. But there are, I think, ways we can make this better. So we're trialing different things. We're going to look at how we perceive time in the trauma bay. I think we have a clock, but it's not digital or analog, which, you know, at 3 a.m. just maybe you can't read time as well. It could be, maybe we need a stopwatch, you know, patient to trauma bay, and the clock starts so that you're more aware of the time. I think there's a lot of different ways we can make these things better to hopefully improve outcomes overall for us and for patients.
Thank you very much.
I think Dr. Epstein mentioned a scribe. That'd be great to have a scribe and be able to have somebody record time. And then we can look at that unbiased, because I think Dr. Ruiz was writing these times down during the resuscitation, and that's how we even have the times. And even he is, you know, managing the trainees as they're doing the procedures, thinking about what to do for the patients. What am I missing? But he's also doing that as he's scribing for himself. So this is definitely a work in progress, but more to come.
Thank you, Dr. Lynde. Thank you very much for your time and the presentation.
Thank you, everyone.
Okay, we have a case for next week, so we hope to see you next week at 12. Thank you very much.